Thank you for the privilege of the podium. Standard disclosure, views are mine and my co-authors and do not represent that of the DoD. I do have one disclaimer. This presentation contains a lot of statistics, so please bear with me and I'll do my best to explain everything without losing anybody or boring you all to death. So first I want to talk briefly about the development of injury scoring systems. The first was developed in the 1970s for the auto industry to compare injuries in car crashes. The nice things about these scores is that they adjust for specific injury characteristics and make them more generalizable and comparable to diverse populations, allowing for analysis. The first AIS showed up on the scene in 1971 was a simple numerical method for ranking and comparing injuries by severity and to standardize those injuries. It was initially used to describe isolated blunt trauma and was found not to be as useful in assessing multiple or penetrating trauma. Therefore, the score was refined in the later 1970s to include the ISS in order to summarize these multiple body areas. This is essentially a summary score that is based on the AIS and is the sum of the squares for the highest values in each of the 3 most severely injured body regions. So next, the new injury severity score came around, which is essentially ISS that we use today, which was developed in order to consider the 3 most severe injuries regardless of body area. The AIS was then updated multiple times to include additional injuries, including more penetrating mechanisms. The military ISS was then developed in 2005 and was updated based on the DoD trauma registry with combat-specific injuries. And a more recent new kid on the block is a trauma ISS, which includes GCS, systolic blood pressure, and respiratory rate at admission. The key thing here is it recognizes that there are other important factors other than just injury characteristics. However, the methodology does place quite a bit of emphasis on initial clinical signs, which may change quickly, and it does not account for age very well with a single cutoff of greater than 55. So the difficulty is that most of these scores do not include host factors such as age, physiology, pre-existing conditions, or changes in status. It is essentially a single score that does not change throughout a hospital course. It does not incorporate the variable sequelae of traumatic injury, including the first early 24 hours or week of traumatic injury. So why should we care? The reality is that these scores are used extensively to improve protective measures devices, determine triage and evacuation priorities, resource allocation, developing training paradigms, directing research efforts, and to allow for honest and data-driven conversations with commanders and families. So with these factors in mind, we sought to design a highly accurate and parsimonious mortality prediction model that incorporated ISS with physiologic variables and early organ failure. We hypothesized that a model that included the sequelae of traumatic injury would be more accurate than that of injury-only characteristics. So in order to conduct this analysis, I looked at the Combat Casualty Critical Care Database, which is essentially an augmented version of the DoD Trauma Registry from early Iraq and Afghanistan, 2002 to 2011. Patients were required to have ICU level care and to be evacuated to at least Longshore Regional Medical Center. So here's the database, all the data elements and where we derived. In particular, I'll note that acute kidney injury was, we obtained it from a creatinine from the DoD-wide CHCS poll, so it was essentially based on the KDIGO criteria. And unfortunately, we had to exclude quite a few people based on missing data, leaving almost 4,000 for final analysis. So in order to conduct this analysis, we started out with the following plan a priori. We would look at a univariate logistic regression for mortality risk, follow that up with a multivariate logistic regression with those variables. We would then take our significant variables and backwards select into multivariate models where we'd look at the receiver operating curves to compare the AUC of each model, and then look at bivariate chi-square to compare these areas under the curves. So here you'll notice our multivariate model with each of those carrying a significant mortality risk. So then we looked at the receiver operating curves, areas under the curve. So ISS alone had an area under the curve of 0.86, which is pretty decent. It just demonstrates how good a predictive tool it is. AKI alone was at 0.74, and adding AKI stage added significantly to the ISS overall, giving a new model of 0.905. So I hope I don't lose anybody here, but this slide essentially highlights that by conducting this analysis, we're able to develop an equation that could predict mortality based on the ISS score and AKI stage. This would allow for simple app-based calculations by plugging in AKI stage and ISS. So here's the receiver operating curves. Here you notice in blue the AKI alone, in green the ISS, and you'll note in red the combined model. And obviously the best model we want here would be one that goes up and to the left. And you'll notice how it significantly improves, in particular at the lower ISS scores, which would improve your positive and negative predictive value at these specific scores. So next we use a bootstrapping technique to internally validate the cohort. While it's not as ideal as validating an external cohort, this uses a method of removal and replacement of random variables in order to develop a confidence interval. You note that due to the large size of the cohort, the confidence intervals remain significant when compared to ISS alone. So this leads me to my fundamental question. Have we been approaching mortality prediction in the wrong way? Mortality risk inherently changes after injury depending on changes in the patient's status. While injury characteristics are an important and validated outcome metric, they fail to take into account the inherent unpredictable nature of hospital course. Subsequent development of serious morbidity can dramatically change mortality risk beyond that initial injury. So just in order to break this down a bit further, I wanted to look at mortality risk by AKI stage, as well as when development of AKI occurred. You notice that nearly 70% of AKI developed in the first 24 to 48 hours, indicating a dramatic change in patients' hospital status early on in their hospital course. So limitations, of course, in this type of study, there are many. The in-hospital morbidity was limited to AKI based on the CHCS data pool. And the vital signs were upon presentation only, not incorporated into the model. Outside of that, there's no external validation cohort. AKI was based on creatinine only, not on urine output or initiation of dialysis. However, the key point here is I want to show you that this serves as a proof of concept. So in conclusion, mortality prediction should recognize that risk changes and variable throughout hospital course. Combining injury characteristics with subsequent morbidity increases the accuracy and predictability of these risk models. And a learning model can incorporate data in real time. So lastly, I'd like to highlight how this has relevance to all of us. Working with big data has its challenges, but essentially follows a simple paradigm. As we accumulate data, we are able to evaluate and design care. We're then able to apply that knowledge in small studies prospectively. This then allows us to see what does and does not work, which allows us to adjust practice paradigms that can get applied back into the field broadly. In this type of system, practice continuously influences research, and research continuously influences practice, allowing us to learn from every injury on the battlefield. The good news is that we've started to do this and we're getting better at it. It is worth noting that the Joint Trauma System and DoD Trauma Registry are relatively new developments, and particularly with their ability to capture this sort of data. And the military has only begun to tap into the research potential that big data allows. This will allow for accurate real-time data that will allow for accurate morbidity and mortality prediction, and I look forward to see where we're going. Thank you very much for the privilege of presenting.